want to thank each and every one of you. We had an overwhelming response to the question and answer session that we had after the initial conference. And also just when people have been able to finally watch the presentations, even recorded, they're just so impressed and so grateful at how well each of you were able to describe things in terms that everyone could understand. And so I just want to thank you so much for your time, and also for the energy that it does take to make sure that the information that you are giving everyone, that everybody can understand it, not just researchers and doctors or people that understand at a high level. So for those that are listening and attending the webinar, there is a question and answer box down at the bottom. So if you do have any questions, we do have many questions to get through that came in during our first question and answer, and we'll do our best to address those questions. And so the first, if we want to get right to it, the first one, I think, was for Vulcan, and families wanted to know if there was a way for them to get involved in the facial gestalt research and being able to provide information that would actually help diagnose more individuals.
Yes, I mean, theoretically, there's a possibility that, and we will be very happy to enroll everybody, or like as many kids as possible. And like we also need facial photos at different ages, again, to establish age specific, those, like the technical term is facial gestalt. How can I say, how these kids look, and that would be help again for the future kids, like who are waiting their diagnosis because of the limitations that we discussed in those presentations as well. The only thing is, like, there is some delay in terms of like logistics from our end. That's why, like, I haven't been able to reach out to everybody, but to your end, we also, you know, we are trying to find a way to not duplicate the efforts that has been put forward by Simon's VIP as well, and see how to combine all these efforts. So when we are ready to kick off, like, I will reach out to everybody, and we will welcome to everybody for those for that study.
Terrific, thank you. This question was for Dr. Dominguez, I believe, or Heike or Dr. Dominguez, about how CK2 affects embryonic development, and what does that mean for the development and efficacy of future treatments and a cure?
So we know that CK2 is absolutely important for embryonic development. The embryo cannot survive without CK2. The patients will have an altered function of CK2, what will mean that the embryos, as they grow, they may have some differences with an embryo that has CK2 that is unaltered or non-mutated. And regarding treatments during embryonic development, that is difficult to predict right now. For example, all women know that they have to take prenatal vitamins, including folic acid. This was because it was discovered a long time ago that folic acid, that is something normal that you need to take in the diet. It's just a vitamin. It helps with the closure of the spine. So until we know how things happen, how CK2 affects embryonic development, we won't know if we will be able to find something that could help during embryonic development. Is that okay as an answer?
I think probably the person that asked the question could only answer that, but it seems good. seems to answer it to me. Dr. Riepholz had mentioned CK2 has been studied in connection with cancer and COVID-19 recently. And the question is, does that mean someone with a mutation in CSNK2A1 is more likely to get cancer or COVID-19?
I can answer to the cancer part while Heike finds her microphone. We are doing some analysis in my laboratory of people that have mutations on CK2 and cancer, and we will be able to have at least, how do you say, not an answer to that question, but something that will tell if people that have mutations in cancer have the same mutations that the patients with CNDS have, or they have other mutations. So we'll be able to answer that question soon.
So yes, I can join in now. Sorry. What is generally known for cancer is that, yes, CK2 is overexpressed or more active. So what that would mean if one just takes that concept to OCNDS patients, it would mean the contrary, right? That they have less of, might be better protected from developing cancers because they have theoretically, from what we think as of now, they have less activity of CK2. And for COVID, I think it would be the same thing, but we just don't know really enough. It has been studied by one group that CK2 is being used by the virus to propagate itself in human cells. And therefore, yes, if it were like a simple answer, one could imagine if one has less CK2 activity, that maybe the virus has less possibilities to spread. But this is something that's really purely speculation, and we cannot definitely, I mean, it would be completely wrong to say that there would be a protection. No, this is not studied, and this cannot be so easily deducted like that. So also for cancer, it's a theoretical notion that I'm giving here, but it has not been studied per se. Is that good?
I want to make one comment on this. So, like I said this before, there are many genes that have been implicated in cancer development, but somatic cancer development, and later found to be associated with a neurodevelopmental disorder. But the norm is not that we also expect a cancer development in those individuals. So even, for example, if an individual carries mutation A, let's say in their blood, the germline, and if that mutation is a very well-known, for example, cancer mutation, we still may not see any cancer development. We don't know why, or the answers to these like dilemmas or like seemingly discrepancies, but they are usually different entities.
Thank you. This is more of a specific question, but I think a lot of people would like to know the answer to it. And it's, I have an 8-year-old daughter with OCNDS. We live in the UK. She is recently receiving speech and language therapy, which they use the acronym SALT, during term time, which I assume means during school time. And they are trying to fight for services throughout the year, but the council is refusing to grant funding for this. Are you aware of any studies, papers, etc., which would help their case by saying that speech and language therapy needs to be continuous throughout a year to be the greatest benefit to a person receiving it that has OCNDS?
So I definitely don't know of anything for OCNDS specifically, but in the United States, we have something called extended school year, which is for many children who have neurodevelopmental disabilities or special educational needs. And it's very well established in the United States that there's round the year school, because if it's not during the summertime, when there's a break, there would be a loss there. That is that it's not true regression, but that children need to continue supports to continue those skills that they have. And that's true of speech therapy as well as other therapies. I don't know, as I said, of anything with OCNDS, but it stands to reason in terms of being so similar to the other special educational needs we have in the US, that this would be very, in terms of advocacy, very easy to advocate for. So I don't know the process within the NHS within the UK, and I don't know the educational system in the UK. I apologize for that. But in the United States, this would be very easy to get a provider, either genetics provider, neurologist, developmental pediatrician, or even general pediatrician, to write a letter of medical necessity to support that.
Thank you. That's really helpful, I think. Are there any doctors who specialize in OCNDS that families can consult with?
So what I would say is there aren't many of you out there. And so just based on how you're spread around the world, it's difficult for any one of your doctors to get very much experience. I would say most doctors I meet, even the specialists, have seen, if they've seen one patient, that's a good thing. And very rarely they may have seen two. What I will offer is that I'll put myself out there. Obviously, I'm happy to answer the questions that are coming in through mediums like this. And if there are very, very specific questions that you have, I do have the option of what I call a clinical visit. So it's something where I'm providing experience and advice for you or your child based on your specific symptoms, not just sort of generically. And we can now do that for individuals around the world. So we do it by video visit, not dissimilar from what we're doing now. In the United States, we do take insurance. So if individuals have an US insurance, there are ways of having that covered. Outside of the United States, we try and make this relatively inexpensive, but there is a small fee that I don't know how your healthcare works and whether or not that would be covered, but we do offer this as a service for patients around the world. And I can, in the chat, if I can do that, I'll put a phone number and my email address. You can contact me if that's helpful.
Fantastic. Thank you so much. We have a question about kind of something that orthodontists and dentists are seeing. They're noticing growth defects in the jaw area of some OCNDS patients. And forgive me because I don't know the mouth very well. Is it maxilla? They're noticing defects in the maxilla and the mandible. And have you heard of, or are you seeing this in other children with OCNDS?
This is also a little bit related to the facial expression, that this part, you call it, right, maxilla. It looks like, I mean, we haven't documented these, but it looks like there's a little bit underdevelopment. So which wouldn't leave space for the teeth to grow and align properly. And also there are like other like mandibular problems as well. So for these reasons, and that we see dental problems in the kids with OCNDS, as well as like many other neurodevelopmental syndromes. So there's also other aspects to this. I think Dr. Chang can touch on those as well.
What I was going to say is that it gets more complicated because some of the things, some children are sensitive in terms of going to the dentist or orthodontist. And so to be able to go in to do even routine oral cleaning, checking for cavities, much less things like braces or other things that need to be done to straighten the teeth or to make room, it becomes a bit more challenging. So for individuals where it's a really serious problem, there are medications that can be used for sedation during those visits, or when it's really extreme, and hopefully this doesn't happen with anyone, but when it's really extreme, I have had some children that need to go under general anesthesia to the operating room if there are many, many sort of decayed teeth and they have to do some more serious things in terms of either pulling teeth or when it gets to wisdom teeth, just because it may be challenging for them to sit still in a regular visit.
Thank you. Do you see apraxia of speech in those with OCNDS?
The answer to that is definitely. So for people who don't know what that means, and that would be most people, apraxia of speech, there is apraxia of other ways that you move your body, but with apraxia of speech, it's a problem in terms of motor planning. And when you think about it, if you start talking, you'll realize that you move your lips, you move your tongue, you move the back of your throat, you move all of your mouth muscles to be able to form words in whatever language you're forming them. And it's quite complicated. And for people to understand how that comes about and to get the sounds out just right takes a lot of work, a lot of practice, a lot of work. You probably can't even remember yourself how you learned to speak. I certainly can't, but it was trial and error. You made a sound and you realized that sound was a sound you wanted to make, and you practiced until you got that to be that sound plus that combination of sounds. Your speech therapist, if they're good, will work with the children in terms of breaking down those very complex motions into individual simpler motions, and working on first specific, whether it's a ba, ba, ba sound, which is a little bit easier in terms of things, and then progressing forward. But it really takes a patient speech therapist, and then in certain cases, being able to also teach you as parents how to reinforce that. But yes, the answer is it is apraxia of speech as part of this. That doesn't help solve the problem exactly, because it still, in terms of just takes a good speech therapist with a lot of practice.
What types of intervention are recommended to treat OCNDS symptoms?
So we did a little bit of this before, so just to save time, I'll say that really the focus is largely on the brain and development and behavior and epilepsy. To me, those are the most important things that we see consistently for everyone. Each child is a little bit different. And again, we won't go into it, whether that's just because we're all a little bit different or because the variation in the gene CSNK2A1 is sometimes different one person to another. We don't really understand yet. That's really part of what we're trying to learn. But everyone has some sort of manifestation of the brain and behavior, I guess is the way I would think about it. Again, I think it's important to screen for seizures or epilepsy and to get them under control if possible. Otherwise, that produces challenges with other things. And then the other manifestations in terms of the developmental challenges, the learning challenges, really require a tailored system with someone who knows your child and knows your child right now, because your child is going to change as they grow up and as they develop additional skills. So with that, it really takes a good team of therapists. It's oftentimes physical therapists. They help with in terms of big muscle movements, walking, running, jumping, climbing. Occupational therapists helping with fine motor skills or hand skills. And then a speech therapist who can help with speech or communication more broadly. Some individuals also have behavioral challenges that can be problems with attention or focusing. Sometimes that needs medication. Some individuals can have problems with anxiety or autism. Sometimes that means a behavioral modification in terms of making things predictable so that they're less anxious and doing things that will help in terms of gradually sensitizing an individual, getting them used to different situations, different feels, different being around different people, different sounds, different smells. All of those things can help in terms of gradually getting used to those. So those tend to be, I would say, in my opinion, at least the things that are very common to almost everyone in the community, is to have one or more of those issues to deal with. And again, the educational system, I know some people wonder how to tailor that. It's hard to say that when we're talking to a global community because there are so many different options. But I think as a parent, I would just urge you to advocate for your child, to make sure wherever you live that you feel you've got someone that's championing your child and really advocating to tailor that system for the resources they need. Whether it's the classroom size, whether it's the type of teacher, whether it's the exact curriculum, whether it's how many months per year, but all of those dimensions are important and can be helpful.
We definitely have a list of questions, but we had a question come through on the Q&A. It says, since most providers aren't familiar with OCNDS, is there anything specifically you'd advise us to tell them about it? We have a psychoeducational assessment coming up in a few weeks, and we are dealing with school avoidance and irritability and concentration issues. Would knowing about a genetic diagnosis be important for providers to know in regards to any medication or therapy recommendations?
So I'll start and Dr. Orr can chime in if he has other advice. I would say that I'm going to give the community a challenge and we'll see if we can do it together. So what I would like to be able to do or have what I would call clinical care guidelines, or in other words, best practices, goals, whether they're related to medical issues and or developmental or educational issues. But what I'd like to have are a set of, there'll be general guidelines we can use for the community, but in my opinion, they should be evidence-based. That is, that they should be based on experience that we have together as a community. And right now, while we have some experience, and I think it's important experience, I still worry that we're not seeing the full age spectrum or maybe not the full diversity spectrum. And we don't have enough information yet for us to be able to be very general about very important recommendations, because once we give those recommendations, I think in a good way, doctors will start to use them. And I don't want them to over-treat your child or do something that's not necessary, and I don't want to miss something. So here's my challenge. If we can get 100 families to be able to share their experience with us, so here's the number, 100 families to be able to put all that information together, I promise you that Dr. Orr and I will write a clinical care guideline for the community that we can use in terms of guiding your care wherever you are, however the age of your child, whatever levels of success or challenges they have, we'll try and write something that will address in a general way all of those things. So that's the challenge. Until then, in terms of doing this, what I would say is, again, as we think about this, it's number one, most important to have someone who knows your child and knows about them right now. So let me be more detailed in what I mean by that. In the United States, in our educational system, in our public educational system, we require that a child is evaluated every 3 years in terms of detailed neuropsychometric assessments. So meeting with a psychologist who can, in a very detailed way, oftentimes over 1 or 2 or even 3 days, be able to do specific testing and assessment to see where the child is, how they learn, and what challenges they have. That's in the public school, and again, for us in the United States, would be free to everyone. And on the basis of that, we develop what are called individualized educational programs, IEP, in the United States. I don't know exactly, again, for the global community, what's available in every single country or every single school district, but my hope would be that you could advocate for something like that, either through your school or, if necessary, through your doctor and through the medical system. Those types of evaluations are also available through the medical system if it's not available through your school. The reason that's my recommendation is that, number one, I can tell you generally, as I said, that all of the children will be slower in learning, will need to have reinforcements, repetition, and will benefit from a smaller classroom size where they can get more individualized support, where they can get someone who can fine tune the curriculum towards their needs, and where they can have someone who can help with problems with wandering attention, because a smaller classroom size means there are fewer distractions and that they can be one-on-one, oftentimes working with the individual. Again, I don't know for any one person if they have autism. I can say that a certain fraction of our community, oftentimes it's about 20 to 30% of our community does have autism. And if that's the case for your child, then you might need additional supports in terms of being able to help with some of those autistic features, help with some of the learning social skills, learning to interact with others, learning some of the things that might be more challenging. So in those cases, again, someone who knows your child and knows your child's special needs can give even more specific recommendations than I can when I'm trying to cover the full spectrum or everyone who's under the OCNDS title. As I said, the other thing that's important, though, is to get that assessment repeatedly, because what your child looks like at 5 versus 15 might be different, and we want to be able to continue to tailor what we can offer based on improved technologies, based on additional changes with your child over time, and based on what we're learning as a whole community here today about OCNDS.
Thank you so much. I think that's really helpful. It covers a lot of the questions that we received in such a succinct way. So I can actually check off the box for like 5 questions in that one answer. So thank you. I appreciate that. I think that being said, with the challenge that you issued, one of the questions is, what can I do to help be part of the research process and help find a treatment or a cure? That's on one spectrum of it. But the challenge that you issued was that you would actually be able to establish kind of a standard of care or have some care guidelines for OCNDS. Are the process for both kind of one and the same? How do you participate in that challenge?
So I am going to put right now in the chat, I think we may have said this before, but Simon's Searchlight is the URL or the website that I put in the chat. You can certainly go in there, and there's a blue Join Us button in terms of joining that. The process, as a reminder for doing that, is that we'll ask for a copy either of your actual genetic test report or a doctor's note or consultation that describes that genetic result. And we're doing that simply because we want to make sure you're in the right club, that your child has OCNDS. And as I had mentioned before, there are some different genetic changes within the gene, and we're trying to also understand if it matters what the genetic changes in terms of the features. Once you provide that genetic test report, a series of things happen. Number one is that you have the opportunity to speak with one of the genetic counselors who works for me. And the good thing about that is they know OCNDS, and they may be able to answer some more of the specific questions that you have as you have a conversation about how your child is doing. There are some standard things that we want to learn about, everything from growth, development, infections, behavioral issues, but all the things that you have questions about, we're collecting the data, and those data will help us to come up with those clinical care guidelines. So by participating in that research, we'll be able to see the experience and be able to answer some of the questions you have. Does this medication work? Does something change over time? Do I have to worry about something in the future? We need to get the data from people's experience, which depends in part on how old that child is, to know if they can help us answer questions. So if a child is 5 years old, they can answer a lot of questions up until age 5, but they can't yet answer questions about what happens at 15. We'll have to use other children who are over 15 to answer those questions. So by doing this all together, it's really, I think I'll give you the dirty little secret, is it's really your research. I'm helping you. I'm behind the scenes supporting you in terms of making sure that we do it consistently, to make sure that it translates in a way that doctors and insurers and teachers understand it. But it's really your research study that is then providing those clinical care guidelines. And so it's your voice. I just get to help you to be able to amplify it and make sure that people will actually believe you and be able to take the advice that basically you're giving each other.
Thank you again. We had a specific question that came in of whether or not there have been any cases in which you are aware of that have had a positive outcome with ADHD drugs such as Adderall.
I think I can start that, Shan. So in general, these drugs are underlying genetic disease agnostic drugs. I mean, ADHD can be an isolated problem, but it can also part of a neurodevelopmental disorder, for example. And theoretically, that it is highly possible that these drugs could help. But there are also some potential side effects that need to be taken into account when considering using these drugs. So like if there is a seizure, for example, it might be a little bit risky, or if there is some other problems, health problems, heart problems, etc. So we recommend not, I mean, if there's any direct access to it, not use it without any medical consultation. And in general, again, like these can be helpful. And usually, like we hear, if they are not helpful or if they show an excess side effects in more than like one or two children, like consistently. Other than that, like by consulting your child psychiatrist, child neurologist, they can be tried on.
I'm sorry, I wasn't sure if it was going to be two-part, but you took that question. Thank you. Dr. Chung, for whatever reason, what you're putting in the chat box or is not coming up for everyone. Sorry, so I was busy cutting and pasting. Thank you, Elizabeth, for letting me know that. We get this question a lot, so I apologize. It didn't look like it was highlighted in our last question and answer session, and I know we've had several different ones with our researchers, and so let's just put this to bed. And people want to know: is there a reduction? Oh, sorry. Since there's a reduction of CK2 protein when someone has CSNK2A1, is there a type of protein that you could eat that could provide therapeutic relief for those with OCNDS? And I know we've asked this many times in many different forums, but today we are just going to put it to bed and never ask it again, and just put it on our website at that point too.
The short answer is no. Yeah. I can rest my case.
So whatever protein you eat, you're going to digest it right away, you know? So if you eat an egg and you eat a lot of protein, it will be digested, it will be broken down, and it will in your stomach be not the same protein anymore than what you took. So even if we could, for example, make CK2 as a protein, which we can do in the lab, and you would eat it, that would not end up anywhere in a helpful manner. No, eating proteins will only give you the building blocks to make proteins yourself.
Thank you so much for clarifying that issue.
One comment that I can make, I heard of like some news about using choline supplements, for example, for other neurodevelopmental disorders. But if, for example, this question is related to this anyway, we don't know if it is helpful or harmful. I mean, again, theoretically, it doesn't look harmful, but we don't have any data on its effectiveness as well. And again, theoretically, I mean, we don't think that it will change or it will make an enormous change. But at times, there might also be no harm in like trying, you know, those things like, you know, with your doctors.
However, I just have to say that we have other ways of controlling proteins that are not through eating. So.
There was a follow-up question to what Dr. Oker was just mentioning about the supplement, and they asked, is that the NAC supplement?
Not to my knowledge, actually, but is it
NAC, I think it's N-acetylcysteine or something.
Yeah.
No?
Yes, it is an acetylcysteine. I don't think so. I mean, if I'm not wrong, it might be a yolk protein, I guess, that's coming from egg. Something, but I mean, I might need to look at it again.
And we may have touched upon this before, but I know it's something that comes up on all of our calls. So again, maybe to finally sort of put this issue to rest, with constipation, what can be done to help our children, and maybe a little bit of background of why in potentially OCNDS or just neurodevelopmental syndromes do we see constipation as a huge symptom?
So maybe I'll take that one. So many of you notice that your children's muscle tone is low or they're hypotonic. And in the same way, the muscle tone in the intestine can be low. And so you need to have muscles to be able to squeeze the intestine to move things along. And if those muscles are not as strong, if they're not pushing as hard, things at the end of this in the intestine can get stuck there. And when they get stuck there for a long time, that is basically what constipation is. Things are not moving through the system and not moving out of the system. And some of the children may not even realize it, but they may not be their best when they're uncomfortable. And so that can be maybe not something they can tell you that's happening. They can't tell you why they don't feel their best, but they're off. So with that, it can be helpful to do something to keep individuals regular. I won't say there's a magic one-size solution to this. There are many different things to try, and you just have to try and see what works. And sometimes a pediatric gastroenterologist can help you in terms of medications. You can start with the most natural things. Sometimes that alone will help. And it's a combination of specific foods that will help to keep you regular. So that can be, and I know it sounds like a cliche, but it really works for a reason. Things like prune juice, things like fiber in your diet. These can be in the morning, things like bran muffin, bran cereal, other things that have high fiber can keep things moving along. And when you find something that works, stick with it is the basic idea. Some individuals actually may have some issues with lactose or different milk products or dairy products. If they're not severely lactose intolerant, sometimes it helps to keep things moving along for certain people. That is that it sort of, as I said, kind of grease to the wheels in terms of moving things along. For some people, there are medications that are helpful. I should have said before that, for some, there are actually fiber supplements that you can add. So besides a bran muffin, bran cereal, there are actually fiber supplements that you can buy in the grocery store or in the drugstore. They're over the counter. You can add them to water. You can add them to juice, but that's something that has more fiber in that also to keep things flowing. The next stage after that is there are stool softeners. So this is something like colace that helps the stool to be sort of easier to push through so it doesn't get so hard. And that can be helpful in some cases. And when it gets to be even more in terms of helping things, there are medications like Miralax, which will really help things move along. It keeps more water in the intestine and so helps things to flush out the system. And in some cases, there are things that go even beyond that. To do anything beyond that, you should definitely be talking with a doctor, a gastroenterologist. Some individuals require more than one of those. both diet and sometimes also something in terms of a medication. What I tend to find, though, is that when you get to a good point in terms of balance, it tends to, as long as things don't change, diet doesn't change, medications don't change, that formula tends to work. The only thing I've seen where things tend to change is sometimes during puberty. So as hormones are changing in children, their bodies are changing and they're growing, sometimes I'll see that you may need to sort of figure out, if there is a change, how to make adjustments, again, to the diet or to the medications.
I think this question is kind of in addition to medications, what can you do otherwise as far as the behaviors that surround toileting? So we had a specific question that says that their child is 7 and still refuses to identify and verbalize that they need to take or have a bowel movement. And when I asked to check, he knows he's had a small accident. Is there something I can do to help him take ownership of going independently, or do I continue just prompting and having bathroom routines?
So this is, anyway, if we can figure out how to do this, we've done a whole lecture on this basically, and there is something somewhere on Simon Searchlight that goes over this in detail. But the basic idea is, if the bowel movements are predictable, and for some kids they are, for some kids they aren't, but I start with trying to make the bowel movements relatively predictable, and then to be able to have potty time that goes with that time. So as an example, if the way the body is working and is that it happens in the morning after breakfast, or it happens in the evening after dinner, to take time when someone is sitting on the potty, a very stable situation so that the feet are on the ground, so whatever the height of the potty is, so that they're not worried about falling in, they're not worried about being unstable, but being able to sit there until something happens. And sometimes that means reading a story on the potty. I know parents, I'm sorry about all the details, but I think most parents are okay with this, but reading a story on the potty, whether it's watching something on a tablet, a little movie or something, having singing time, but something that's distracting. And then I personally have used a reward system in terms of stickers. So when someone sits on the potty and does something good, then we have a sticker chart to be able to have praise or be able to acknowledge that that's happened. It's more in not waiting for them to have the urge and to tell you. It's more the sense of getting their body to be regular and you accommodating them more than them accommodating you, if you know what that means. Because at the beginning, it's hard for them to know when something's going to happen, and it's just not something that literally they're thinking about. If you can do that, then at that point, that's a huge plus. And I know in terms of being able to go to certain schools or school settings, the schools will want you, to be able to have someone who's toilet trained. The other part of that, which is number 1, as we say in the United States, besides number 2, number 1 tends to be a matter of frequency. So it's just going and having toilet time at a lot of intervals until they get to the point of being able to do it. And whether that's every 2 hours, but sometimes it's taking a break and just going again to the toilet every 2 hours to number 1 in terms of being able to make sure someone stays dry. And dry at night takes a long time. That's kind of another story for another day, but that takes a long time to get there, so be patient.
Thank you. And we'll look for that Simon Searchlight webinar about toileting to have it available for our community. Thank you for letting us know about it. We have a question. Immunology comes up a lot in our in our group, excuse me. And have any connections, discoveries have made it more clear as to the ways that OCNDS affects things in the area of immunology, as far as how it's showing up in individuals' bodies and affecting their immune system, or
So it looks like there is some connection. And we have particularly a group in Europe they're willing to work on what those problems are. And I kind of like connected a few of you with those collaborators, but the studies are still being done, and we haven't got any specific results or any preliminary results. But when we look at the picture, the immunological problems in all the kids, so far, actually, we haven't been able to see a consistent pattern. Yes, there are some problems, and there are like some low immunoglobulin levels or some other problems, but we are still missing the connecting piece of all those immunological issues. But it looks like on top of an immunologic predisposition or like a predisposition to infections due to the low muscle tone, etc., there looks like there's something going on in the immunological system as well. But we are still researching that.
Thank you. We had a question that came in a few days ago about your talk, Dr. Oker, and that you had mentioned regression and that you would be touching it in your talk, but they didn't hear it mentioned. So maybe they may have missed it, but they wanted to know, is there regression in OCNDS, what it looks like, or at what age we might expect to see it?
Did I say regression? I must have misspoken. I'm sorry, I haven't watched my talk again, and I don't remember yet, but I may have said that if there is, just to give some examples, like what we can find or not find between two variant groups, whether there is a regression in one or not in the other, that if I used it, I must have used it in this meaning. Other than that, I guess, I know of a few kids with regressions, at least I heard of, but I don't know all the official documentation about that. Other than that, like when we talk about regression in genetic syndromes, it is a little bit different. It's usually the kids have normal development at until a certain age, like 2 to 3 years of age, and then they gain some neurodevelopmental abilities, and then they start losing those. But we are not aware of this kind of problem in any kid with OCNDS. But sometimes they might have some up and downs due to some seasonal changes, like starting a school, or any other achievement, milestones, etc., some like infectious disease. These are not normal, changes. But I don't know that we have any kid with the regression in the definition that we usually have.
Thank you. There was a follow-up question that came in about immunology, and maybe you answered it. It says, is there a link between immunologic issues and this genetic outcome? But I'm not sure if she finished her question or if you answered it. Oh, sorry. She says, so are there any correlations between OCNDS and parents with underlying disorders?
No. Not to our knowledge. You mean like if there is any underlying immunological problems in any parent that will create a predisposition for OCNDS in the kid? If that was the question, no.
That was the question, yes.
No.
And I know that we've answered this before, but again, I think we could maybe put this question to rest, was whether you believe it's possible to find a treatment or a cure for OCNDS. Dr. Dominguez, you're shaking your head. Do you want to go first?
I can go. Oh, sorry.
Wendy or Volkan can go first.
I think Dr. Chang is the best person to answer this. And I mean, in the last 30 years, we have seen a lot that look impossible in genetics. So yes, I believe and I hope. I mean, to be realistic, we don't know when this could happen. But yeah, I mean, the possibility is there.
So I'll say as a all of us, I think, would say, this is why we do what we do, right? I mean, we are here today as part of that effort to try and come up with treatments and someday maybe even a cure. I know that's a long way off in terms, I call it the capital C word of cure. So I think we're aspirational to that. But in terms of treatments and supports, that's why we're here. That's why you're here this weekend. We're all working together towards that. I do think it's going to take some time, and I think we have to be in this for the long run. I can say that, and I think I speak for at least the five of us that are here on the panel, and I'll include you in that too, Jennifer. I'm pretty sure this is the case. We're in this for the long run in terms of doing this. We're not going anywhere. We know this is going to take some time, but we're dedicated to this particular mission and this cause, and we have the patience to do what we need to get there. I hope you can still hear me, but with this, I do think, as Dr. Kaur was saying, I'm going to call them enabling technologies. So improvements, innovations that I know are coming in the field of genetics. They are not exclusive for this condition. They actually will work for many different conditions, especially many different brain conditions in children. And so I think our task is to be able to keep your children as healthy and learning as much as possible to prepare them for the time when some of these technologies will allow us to be able to move things forward. And with this, I think it's very important as a community to be able to make this as easy as possible when these enabling technologies come forward to put us at the front of the line. Because when these technologies come forward, there are going to be many, many other people who are also going to want to use those technologies for their conditions. So I want us to be prepared as a community to be able to test these new conditions and move them forward as quickly as possible. So that's why we ask you all to do some things today, even though we don't know when we need them. We don't know if we need them tomorrow or in 2023 or 2025, but we're thinking ahead for you. So just trust us as we're making these recommendations in terms of doing specific things, asking you for information, asking you for blood samples, asking you to be able to tell us about your experiences and even do some things that might seem like a whole lot of questions and a whole lot of time that you spend doing this. But we're all doing this in preparation to be able to test some of the new treatment options that will be available in the future.
And just adding what Dr. Chang just said, the more information you give us, the better our research will be, so that we are not flying blind, but we are targeting our research to the disease and the manifestations of the disease.
I'm not sure if on your end you can see any of the questions that are coming through, but as kind of a follow-up about the information that you're seeking, we had a question about, are you capturing any data from parents? We know that, we know that some are de novo mutations, but would it not be important to capture this information in your research? What if there is a link with EBV, varicella, HSV latent in dormancy?
We are capturing this data actually, but I mean, these infectious agents, they have been around for thousands of years, and yes, there is a notion that the viral genetic component can go back into the human, but it's not like that. I guess, I mean, these infectious agents, they're very common agents. And I mean, I personally don't think that they have, at least like we don't have any scientific evidence that they have any effect on those mutations. And those de novo mutations looks like following the general pattern that the DNA is not, mutation proof. Like the mutation occurs every now and then, and like we all have like uneven mutations. Some are harmful, some are not. In general, this is just the nature of the DNA's like own, like say, like error in itself. I don't think there's any other outside effect for these mutations to occur.
We have about 2 or 3 minutes left, so we have 2 last questions. The first is, we are newly diagnosed, and we appreciate that we don't know what the future holds for our child, but are there any documented cases of older children, adults living and working independently with OCNDS?
So one thing I'll say is that we don't know of that many adults, period, with OCNDS. So it's a limitation. I do think there are a lot of people out there, both children and adults with OCNDS, who haven't yet been diagnosed. And so I don't think we know the full spectrum or understand all of those details. I won't go into it in much detail, but I am doing things to try and understand the answer to this question. So I've been wondering this same question myself, and I won't have time to explain exactly how I'm doing it, but I am working to try and understand those adults who might be out there doing their thing, living independently, but may not have come to attention. So I don't know if it'll be a year from now or 2 years from now, but I do hope we'll be able to answer that question. But to a blunt no, to my knowledge, I don't know of anyone right now who's living as an independent adult on their own with OCNDS, but I don't think we really have the information to answer that question correctly yet.
So I talked with a few parents when I was at Columbia. And like Ms. Gallo just described, that there are some individuals like in their 30s, but I was told, I haven't talked to those individuals, I was told by their parents that they were able to work a part-time job and they were able to live independently at their own house, but they also need some help. So in terms of these, independent living, you can say that, but like Dr. Chung said, something that we are interested in these neurodevelopmental genetic disorders, that what other neurological problems that we might see in the future. So we have no data on this, and I haven't heard anybody as well.
Sorry, and the last question will just be about autism. We know that everyone that has OCNDS does not have autism and vice versa, but there's we have a lot of families that are told when they're asking for an autism workup or testing that their child isn't old enough yet. And so parents are wondering if the child is displaying kind of different characteristics and traits of autism, should they push for testing at this time, which their child in this instance is 4? Is there a recommended age in which you test for autism?
So you can't really make a diagnosis of autism very accurately before 3. By 3 and above, you can make the diagnosis, but it becomes a more stable diagnosis, or we become more certain the older the child is. In the United States, having an autism diagnosis for many individuals will help them to get certain services. So there are things called ABA therapy, applied behavioral therapy that is used for autism. And so many parents actually are looking for that diagnosis because it qualifies the child for those special educational services. It's not to say that if you don't have an autism diagnosis, you can also still get special educational services simply with the OCNDS diagnosis or some other neurodevelopmental diagnosis. So you don't strictly have to have an autism diagnosis for that. At this point, we don't have any medicines that treat specifically autism, so it doesn't help you in terms of having a diagnosis because there's a medicine, a pill, an injection you can take that'll get rid of the autism. So the real dimension that it ends up is, like I said, advocating for services in the United States and in some other parts of the world that work similar to the United States. It can't be helpful in that way as well.
I can't thank you all enough for giving us your time on a Sunday. Thank you so much for doing this additional question and answer session for our community. There are so many questions and so many unanswered questions, but I think today is incredibly helpful that it did answer a lot of questions people have continuously about OCNDS. And it's great to know that you and Dr. Oker, Dr. Chung and Dr. Oker are working on kind of standard of care guidelines. It's something I think when everyone is diagnosed with OCNDS, it is one of the questions that they have. What can we do now besides is there a treatment or a cure? And I can't thank Dr. Dominguez and Dr. Reepoltz enough for all the work they do day in and day out in the lab. And thank you so much for your dedication and your time. We're so grateful. And I think this wraps up our Q&A. We thank you for everyone for participating. This will be recorded. I mean, this has been recorded and will be available for our community. And thank you so much.
Thank you.
Thank you, Jennifer, for hosting and getting us together. Bye.
Thank you.
Bye-bye.
Bye-bye.
Thank you.